6 measures we would do as soon as we were elected. 5 of them became law. 1 we couldn't get, which was enabling the Secretary of HHS to negotiate for lower prices. Big resistance to that, and you will see that in the ads on TV. And they won't say it quite that way, but that's part of that. They know that is the heart of the matter. And central to the frustration that people have is the fact that they hear that people in other countries are paying 1/4, 1/5, 1/6 of what we are paying here for the exact same brand name drug. So that was the question I was going to get around to answer. And here's what this legislation does. What it does is it takes the 6 similar economies to us: Australia, Japan, the UK, Germany, France. Japan, did I say? Anyway, it takes those, Australia, those countries, and takes their average or their mean. That'll be up to your committee to decide whether it's average or mean, but say the average for the sake of our discussion now. And whatever that price is, it says that in the U.S., the companies cannot charge more than 1.120% of that. So that takes it all the way down. And in the legislation, there are non-compliance penalties and the rest if they don't do that. But this is going to amount to enormous savings for families, for hospitals, for everyone, for the public role. You talk about what has happened here in terms of cost, and the cost of prescription, the rising cost of prescription drug brings to that. So this is absolutely essential. And I do believe that we can do this in a nonpartisan or bipartisan way. The President says to me that he wants to do this. I take that sincerely. This was part of our agenda in the 2018 election. For the people, we would lower the cost of health care, lower the cost of prescription drugs, as was mentioned. So this is something that we think we can do working together. We have good, shall we say, indications from the administration that the nature of the legislation is consistent with what they have indicated they might be supportive of. There are other considerations that have entered the situation. So in any event, we think public sentiment is everything, and our members across the country are having events about this subject over this district work period. I'm sure that none of them is as wonderful as the one we are having here because of Susan and because of all of you. And to the University of Washington, we have University of California, San Francisco. I'm from Baltimore, Johns Hopkins. So there's kind of like a little, I don't want to say competition, but friendly, and the University of Washington got way ahead of everybody when Senator Magnuson's excellent work in recognizing the important work that you do here, because the NIH is very important to all of this, about the extramural granting from the National Institutes of Health to institutions of excellence is so important too. So thank you all for what you have done. I consider this a very important. I want to hear what you all have to say about this, because we came to hear, not only to say where we are, but how we could improve it. So thank you. And again, Suzan, Congresswoman Delbene, is on the Committee of Jurisdiction, not only that, on the Subcommittee of Jurisdiction. So she'll be right there when they make decisions about, with all these savings, how will that money be spent? How can we make all this much more transparent? There's still things not written into the bill, but left further to the committees, which wrote the bills to begin with, but now with the benefit of public sentiment, to see where we go from here. And
we'll be starting to work on that when we get back again next week.
Right away.
You talked about negotiating the most expensive drugs that don't have competition would be negotiated, and you said the maximum price would be 120% of this international average. But that won't just apply to Medicare, so I wonder if you can talk about how that will impact everyone's drug prices.
Well, thank you for that question. And when in an earlier time, when we were doing the 6 we were saying that negotiate the price of prescription drugs for Medicare, because that would reduce the public money, and the impact on seniors in this. But with this legislation, we've taken it to not just Medicare, but also to all who want to participate in it. So it goes beyond Medicare, it goes into private insurance, etc. So this is for everyone.
So yeah, that maximum price would be available to private plans, and they could come up with a lower price if they could get it. But that means that that would have a huge impact on folks everywhere. Now, there's also an important part of the legislation on the out-of-pocket cap, because right now, one of the things that we hear from constituents a lot, and a glaring omission of the current Medicare drug benefit, is the lack of an out-of-pocket cap. I have a constituent, John from Arlington, who told me his wife is in the donut hole, pays $210 every 2 weeks for her medications. And so how will the out-of-pocket cap affect seniors like John and his wife?
Well, one of the breakthroughs in the legislation is that there would be a $2,000 cap, annual cap. And this is really important because it's endless right now in terms of where, especially under the Medicare Part D and the rest of that, there's endless. And some of these drugs are miraculous, but they're also incredibly expensive, endlessly expensive. So there would be a $2,000 cap. Now there is a bill in the Senate, not as, shall we say, transformative as our bill, but it has, $3,500, I think it is, cap in the Senate. So there's a recognition that there has to be a cap. We'll negotiate that, but it's a big difference. The difference is not between $2,000 and $30,000 or $3,500. It's between no cap. We want to keep it as low as possible, and as we see what the savings are, to see if we can't make it some of that benefit flow to our seniors further.
No, I think that's a huge point, and so important for so many people who are paying well over $2,000 in prices every year.
You would be so surprised. And some of these drugs are miraculous. Many of them sprang from basic biomedical research at the National Institutes of Health. And that agency has the miraculous power to cure. And that's a fabulous and wonderful thing. But we want the benefits of it to be for all Americans, not just those who can pay those big prices to it. And so recognizing that many of the private sector innovations have sprung really from the basic biomedical research, we feel there's an obligation for everyone in our country to participate, because everyone helped make it possible.
I have another constituent, Nancy, who's from Kirkland, and she told me how her medications seem to jump in price every 6 months. So there's also part of the legislation to deal with these types of price spikes and prices that are increasing much faster than inflation. And so can you talk a little bit about that?
Well, and again, your committee will weigh in on transparency of how and why do these increases happen. And there has to be people have to know there's going to be a judgment about just why did they increase. But that is the spiking, or even new drugs coming on the market that aren't in the lists that we have now, will be subjected to real scrutiny. But again, the transparency piece is yet to be written. There's some different views on that as to why these unusual spikings, and no certainty in people's lives. People have budgets and the realities of life, and then it changes and it changes and it changes, but the condition does not necessarily is not compatible with how the prices increase. So again, all of these aspects, and that's why hearing individual stories are so important, so that we can have a handle on it in the legislation and a path. When I just want to make this point about how important your being here is today, and I thank you. When we had to protect the Affordable Care Act last year from all the assaults on it, we were successful because there were 10,000 events around the country of people telling their story. Nothing more eloquent than that. The reality of life or death. And so I say to those who have the generosity of spirit of sharing their personal story, which sometimes is sad and sometimes they don't want other people to really be so aware of, that really does make a difference in the quality and the specifics of the legislation. So thank you for that. Moms Rising, where's Kristen, was so much a part of all that we do. Thank you so much for your... Public sentiment is everything. As Lincoln said, public sentiment is everything. With it, you can accomplish almost anything. Without it, practically nothing. So this drumbeat, which was essential in the election last year, I'm not talking politics here, I'm just talking policy. This is it. And to our union friends, I would be going around to union halls talking about pensions, just, related, the economic security of our families. But then I'd hear the questions, and 2/3 of the question were not just about pensions, but about the cost of prescription drugs. So it's just pervasive. It can be addressed. We can do it in a bipartisan way, and we can do it soon. But we can do it better knowing your stories.
Oh, absolutely. And you started off by talking about what an innovative region we have here. We're here right at University of Washington, where we've had so many great innovations, but that's been important throughout our region. And so talk a little bit about how this legislation will actually continue to support innovation.
Well, one of the ads that I've seen on TV on the attack on this, I've said, it's going to hurt innovation. No, it's not going to hurt innovation. In fact, one of the kinds of, some of the unease we have had about how these prices have come to be is that...
Move your mic, they're having trouble hearing you, I think.
Do I have to use my mother of five voice? I don't do that. Is it working now? Okay. One of our concerns about some in the industry, not to paint everyone with the same brush, is that they were spending more money on advertising than they were on research. And yet they were using research as the reason they had to charge us so much. And basically, the U.S. Consumer and patient was subsidizing all these overseas lower prices. It just wasn't right and it wasn't justified. And we do recognize the power of research. Again, the biblical power to cure, discovery, illuminations, inventions. That's so exciting. And but nonetheless, we have to have it be fair in terms of we as taxpayers are paying for much of the original basic biomedical research. And when the companies say that it's going to deter innovation, no, quite the opposite. We will have savings that we can reinvest into innovation that benefits everyone, and not just the bottom line of a pharmaceutical industry. But if you saw the figures of what they spend on advertising versus, not all, but many, on advertising, you think, and of course the advertising just increases the demand. I want that one, right? I could get a generic, but I want the one I saw on TV, so everybody pays more.
Yeah, I started my career doing biomedical research, and
she's so great.
The investment that we make has been incredible in leading to the breakthroughs that we've seen, and that a lot of that research happening here in our region too. So if we have savings, that's more money potentially for NIH, but also more money that we can invest, for example, in Medicare, other places to help patients. But do you also think this could have an impact on premiums that folks are paying if drug prices are lower?
Well, before we go away from Medicare for a second, one of the probably first items on the agenda, with stiff competition for what's first on the agenda, is that we could possibly expand the benefits for Medicare, maybe dental, hearing, visual, and that would be a great thing if we could improve the benefit package of Medicare. And that probably is standing first in line in terms of some. AARP supports the bill. So many organizations support the bill that, shall we say, represent those who would be interested in those benefits. Increase the benefits for Medicare, Medicaid, the investments in innovation, lower cost, just lower cost to the public sector, to the individual, and we'll see how that might affect premiums, but we do have to address the out-of-pocket, whatever it is, whether it's premiums, whether it's drugs, whatever it is, the out-of-pocket has to be addressed. And so when we talk about expanding, and Mr. Executive, you talked about expanding, and Paul, the access to care in this region, and that's really important. I mean, we're so proud of that. In addition, though, what we did for, say, the 150 million families who already had insurance was to increase their benefits. No pre-existing condition as a barrier to care, no lifetime limits or annual limits in terms of what their benefits would be, their insurance would cover. And that was very important as well. But there's still the out-of-pocket issue that in many manifestations of how people participate in the in their health and well-being, and we have to try to lower that.
Well, I want to hear from some of our folks. We have some folks here who have been impacted and have some questions for you. So we're going to start with Dana from Kenmore. We have a mic that we can give to her.
Oh, Dana.
Oh, there you are. I was looking over here for you.
Hi, Dana.
And just introduce yourself, and thanks for being here, too.
Is this on? Oh, there we go. My name's Dana Van Buchen, and I was diagnosed with type 1 diabetes almost 13 years ago, just out of college. Back when I was first diagnosed, my monthly insulin cost was about $75, and I'm still using the same dose, still using the same brand of insulin, but my monthly cost is now over $600. That's a 700% price increase for a medicine that's not optional for me. So if I stop taking insulin, I'll live a few weeks, maybe a few months, but not long. So I also work as a CDE, or a diabetes educator, and I can tell you that many of my own patients are skipping doses or rationing insulin because they can't afford the medication. That causes increasing blood sugar levels, puts them at risk for things like kidney failure, blindness, amputation, nerve damage. So my question is, does this bill address insulin pricing? And if so, what does it do to stop prices from continuing to increase for people like myself?
Well, thank you for that question, because if there's any poster diagnosis or a prescription drug that needs to be addressed, it's insulin, because the industry, some in the industry have just increased the cost so much. Then they'll say, well, we reduced it. Well, but we're still not anywhere near what is affordable and where this all started. So no, insulin is very much a part of the negotiation, and it affects so many people. And while we're on the subject, I want to congratulate, I heard today this was the first dialysis center in the country. It's right here. So congratulations on that. Hopefully we don't get to that point. Not you don't get that, but just relate it. But nonetheless, no, thank you for your question. It affects so many people in our country. It's almost sinful because it's really withholding of something so life-saving and quality of life providing. So thank you for that. And that will be an important part of the committee's further work in terms of not only that it's one of the negotiated drugs, but that it is how they make these increase the price. What's the justification for something like that? If I just may, because you remind me, and I do want to hear the other question. The number of there are so many drugs, but what the bill strives to do is to do the most expensive ones that affect the most people. Now, some people say, well, you should do more. And again, with the savings, what we'd like to do is expand the capacity of the department's ability, their capacity to do even more drugs again and again, but it will have an impact immediately in a very big way.
Yeah, the bill specifically calls out insulin too, because we know it's so important.
It
so,
really is. It's the poster child. Thank you. Thank you.
Our next question is from Genesis. Genesis, who I got to meet with her amazing son, who she's going to tell you about. And so Genesis is from Snohomish. So thanks again for being first. And we talked a lot about the Affordable Care Act early on and the impact that had on her family, and now how important this bill is. So Genesis, thanks.
Yeah, the Affordable Care Act has been huge. So my name is Genesis Avalos. I am a registered nurse, a board member of the Bleeding Disorder Foundation of Washington.
Hold the mic. Yeah.
And most importantly, the mother of Sammy. So Sammy was born with severe hemophilia A. It is a blood clotting disorder that can lead to life-threatening bleeding. To treat this disease, we infuse IV clotting factor into his chest port and also do a subcutaneous injection every week. Sammy's only 5 years old right now, and we've easily spent over $2.5 million on his medication, not including the rest of his care, with no end in sight because there is no cure for this disease. So we're so grateful for the Affordable Care Act because it has allowed us to maintain our private health insurance without worrying about the lifetime maximum and the complicating situation of pre-existing disease. So, with the high price tag on Sammy's medication, we would be bankrupt without the ACA. And with that high price tag, his disease is so rare that we do not see the volume of patients. And so I know HR 3 will only negotiate about 250 medications a year. So if his medication does not make it on that list, how do you see HR 3 affecting drug pricing in the general landscape?
Well, first of all, congratulations on Sammy, and thank you for sharing your story. And in the course of the Affordable Care Act, and both passing it and saving it, moms, dads, little lobbyists, children, the children's stories were the most compelling because some were born with a pre-existing condition, which means a lifetime of pre-existing condition, therefore being prevented from getting the care they need until the Affordable Care Act. So thank you for your recognition of that. One of the possibilities of the savings that we are advocating for is that there would be how else can I say this graciously, a pot of money that would be for investments to be made in what we call orphan drugs, that where not that many people are affected, but the people who are affected in a prohibitive way in terms of cost. So that, again, that's one of the considerations in the legislation yet to be. But that would be, again, Medicare improvements, investments in innovation. Some maybe even we talked earlier about community health centers getting some of the benefit, as well as these low population but big drug bills. That we could invest there for that. And let me just say that there's going to be, we don't have our CBO, our Congressional Budget Office score, but we think there's going to be big savings. We just look at the cost and then see the big savings that will be there. So it'll be transformative in the lives of people, but also in the public sector, the nonprofit sector, the private sector, but also in how we can use those resources a different way that the federal government is spending right now on prescription drugs. So thank you for sharing Sammy's story. Thank you.
Thanks, Dennis. Now Eunice. Eunice is with the American Cancer Society Action Network. She is a fierce advocate and had the chance to work with her for many years.
Fierce.
And I know fierce. And so I wanted to let Eunice ask a question that she has. Thanks.
Thank you. My name is Eunice Hostetter. I'm from Kirkland. And I am a 16-year cancer survivor. On the way here this morning, I heard another survivor say that every day after diagnosis is a good day. I'd like to say it's a great day because you are here and you've taken on this issue, which is so important to so many Americans. And particularly to cancer patients who experience very high drug costs and particularly for Medicare patients who I believe are disadvantaged. because of the current Part D plan.
That's right.
I wanted to share a story about a family member of mine who was diagnosed a year ago with a blood cancer. The short term is MDS. It's a myeloplastic dysplastic syndrome. It's a hard one to say, and that's why I use MDS. But it's a cancer that has required infusions at a cancer center of a drug called Revlimid. I believe I'm saying that correctly. It's a very expensive drug. However, she's been fortunate to have Medicare and also a supplemental policy. Medicare B has covered 80% of the charges. Her supplement has pretty much picked up the rest. So that's been good. However, her doctor has recently recommended that she go on an oral form of that same drug. So she could take a pill at home, which is a very appealing offer to her. However, under Part D, she would go past there's 3 levels as I understand it, and she would actually get up into the catastrophic area, and her out-of-pocket expense would be over $14,000 a year. Unfortunately, she's not a very wealthy person. She survives on a somewhat modest Social Security income, and there's no way she could take on $14,000 a year in drug expenses. So we're very heartened by this proposal. If this law passes and the cap becomes $2,000, I think the convenience of taking a pill rather than making frequent trips to an infusion center would be very appealing. I would like to make a point, however, that I hope could be considered with changes to Medicare in general. This state passed an oral cancer parity law in 2010. My understanding is 42 other states have the same cancer parity law in effect. And what that means is if a patient goes on an oral form of chemo, it's covered at the same rate as
if you're in the hospital.
The inpatient. Medicare does not offer that same protection. And so I don't know how that would fit, but I hope it could be taken into consideration.
Thank you. Well, thank you so much. I'm sorry for you, the challenge that is it your friend or
It's a relative of mine.
relative has. Not that it matters, but I never supported the Medicare Part D plan because we overwhelmingly voted against it, 1-by-1 vote. President Bush was president, and they had to wait all night until he got up to get him to persuade one or more person to vote for it. But in my view, it is a cause of some of the challenges that we face now because it gave away the store to the pharmaceutical industry under the guise of helping seniors. And what seniors get stuck with, this endless catastrophic cost. So that's what we want to address here. The interesting what you're suggesting is about Medicare, that it makes all the sense in the world. Wouldn't you agree? That if they can stay home and take it, and it should be at this, at a savings rather than just having to have it be inpatient. But we'll see how we can work that in.
It's this complication
that
folks don't understand between Medicare Part B, kind of, which if you're at the doctor's office and you get that drug, it's covered in one way, but if you take it at home, it wouldn't be covered because it's Part D. So the out-of-pocket cap would mean that there would be a $2,000 cap, which would help a great deal versus I think you said $11,000 that she would pay, or $14,000. But your point also on what's happening with states too is also a very good point. So.
I used to say we're praying for everyone. In Washington, though, not where we are, it's like faith or science, and we're saying no, we don't have to make that choice. Science is an answer to our prayers. So.
So I know we're running out of time because we've got to make sure we keep you on track because you have a flight. And so I wanted to, first of all, thank you so much again for being here and for spending time and for all of the work on this issue, which we know is so important just from the stories we heard today. And I know there are thousands and thousands of stories right here in our region, and we just expand that across the country. So we're going to work hard. You said this is something that you feel, bipartisan, and we should be able to move through. So maybe we'll just close and just say, tell us how we're working hard on the House side, and so if we get through the House, what you think the prospects are after that.
Well, thank you very much, Congresswoman Delbene, for your leadership in so many ways. Now, strategically, on the Ways and Means Committee, Health Subcommittee, which is part of the committees of responsibility and authority on this subject, and again, coming from a region rich in innovation, it's in the air, it's in the water and the rest, and also thinking in that entrepreneurial way, but how can we do this in a new, fresh way that really gets the results for the future? And again, in so many cases, it's about the children. It's about the children. It can make such a big difference in their lives when we remove all doubt that they will have what they need in a way that is affordable. It can't be accessible unless it's affordable. But let me just say that nothing was more, shall we say, this is going to sound a little political. It's not really intended to be political. It's just a fact. Okay? Nothing was more eloquent to our colleagues than the fact that this issue was the issue in the last election. And people said, how did you make it such an important issue? I said, we didn't make it. It is in every family in America an important issue. And again, 10,000 events around the country, little lobbyists, children, families. I mean, don't get in between when they say this mom's rising, and to say to you, don't get between a parent and the needs of their child when it comes to a difference that public policy can make. So all of that was so, President Lincoln, so eloquent, and that sentiment, and that's why I think everybody there heard about it. It was part of our agenda. That was our For the People agenda, lower the cost of prescription drugs. Boom, like wildfire. It's still, because the problem hasn't gone away. Just because we won and everybody made that statement, the problem hasn't gone away. Obviously, we still have to get that done. And I think that hearing from their own constituents, nothing is more eloquent to a member of Congress or any elected official, right, Senator? And thank you. I saw you shaking your head when you talked about the outpatient parity there. Then the voice of their own constituents. So we're trying to say to people, beat the drum, beat the drum, beat the drum. Make it too hot to handle that they would not pass this legislation. Why wouldn't they? Except that you'll see ads on TV which so completely distort what we are doing, price controls and this and that and that and that, and taking away your this and that. It's really interesting, shall we say, I would say imagination, but that's too good a word for it, but the resourcefulness of those who want to mischaracterize something. And it's about the money. It's about the money. It's either our families are going to pay. So on this, if we all, Democrats, Republicans, nonpartisan, all the rest, if we all have a seat at each other's table and understand why, first and foremost, we know, and how we can do this in the best possible way, so that 20 years from now, or whenever, 15 years from now, people would say, this would have worked, except they didn't do the bill. They had to make compromises. No, let's just do it right. Again, the vote on Medicare Part D was right almost exactly down party lines against it. And I have heads of pharmaceutical companies coming into my office to talk about this, and they'll say, well, we're in this fix because of Medicare Part D, which they all supported, which they all benefited from. But let's assume that everyone is of good heart, wants to get the job done, recognizing that innovation is our responsibility, profit motive in a market economy. That competition is good. So we're not negating that, but we're just saying that the exploitation of the needs of the American people, especially when they see those needs met elsewhere at a much lower price, especially when they're subsidizing it with tax dollars for the basic biomedical research. It's just not fair. So we tried in '06 when we won 6 for '06, 5 became law, 1 did not. We could not get 60 votes and whatever to make it happen then. But now we even have a better bill, more urgency, and a great respect for other views as they weigh in, so that we have the confidence of what we are doing is the right thing to do. It's needed, and that's very well thought out by our committees as to what we are proposing. The humility to listen to any improvements or the other side of the aisle may have or people may have, but we are determined that this will happen. And in my view, it could happen this year. It could happen this year. So thank you for all that you all do in your communities, the generosity of spirit of sharing your stories. And that, again, as I said, Suzan Delbene is a person of great grace, dignity, knowledge, experience, respect that she commands. But she's no nonsense. We don't have meetings to have meetings. We have meetings to get the job done, to get results. So thank you for advancing us and making progress down this way. Thank you for sharing your story. Thank you again. Thank you. I'll tell Mary Kay I saw you. Thank you for your kindness.